Hello, my name is Sujata Somani, and this afternoon I'm going to be talking to you about vanquishing vaginal dryness, treating the genitourinary syndrome of menopause. I have no disclosures. So menopause is a normal life event usually occurs around age 51 to 52 for most women. And as a result of a change in ovarian function, there's a lower level of sex steroids that are present in the body. This can lead to changes in genital tissue over time, and this has been called the genitourinary syndrome of menopause. As a result of longer life expectancy, most women will live up to 40% of their lives in menopause. As I mentioned, there's a decrease in sex steroids, and this can lead to changes of the genital tissues, including the labia majora, minora, clitoris, vestibule, introitus, vagina, urethra, and bladder. So as you can see, pretty much the entire genital tract is affected by changes in lowering of estrogen level. The symptoms can be chronic and progressive over time, meaning that they're really not going to improve over time and can lead to significant problems for patients. The prevalence is quite common. Up to half of all women will have some symptoms of genitourinary syndrome of menopause. And as you can see, unfortunately, only 6 to 7% of these women end up getting any treatment. And this is because many women are unaware that symptoms can progress without treatment and that there are safe and effective treatments available to them. In this survey of more than 3,000 women, as I mentioned before, up to half of all women experience some symptoms. In this group of women, 1/3 of women of that group that had symptoms sought help, and most did not seek help because they believed that their symptoms were a normal part of aging and also thought there were no effective treatments available. So what are some of the signs that women may have? These encompass the prior terminology of vulvovaginal atrophy. So they may have symptoms of vaginal dryness, burning, irritation, as well as sexual symptoms such as lack of lubrication, pain with intercourse, and impaired function, as well as the urinary symptoms of frequency, dysuria, which sometimes also leads to recurrent urinary tract infections. The signs that we may notice on exam include reduced elasticity of the vaginal tissues, pallor, where the vagina seems paler or it can be red, loss of the rugae of the vaginal tissues, as well as fragility of the tissues where they may bleed easily. The pH of the vagina usually changes from the normal acidic pH to a higher pH, and this can lead to a change in the bacteria where there's growth of pathologic bacteria that are present. And women may present with some or all of these symptoms. To be diagnosed with genitourinary syndrome of menopause, these symptoms need to be bothersome and cannot be accounted for by another diagnosis. As far as sexual symptoms, those are also very common. In this study with the survey, they found that up to 63% of women who are in menopause have noticed some changes in the enjoyment of sex, spontaneity, since they now have dryness and may need to use lubricants, as well as the ability to be intimate, and that can affect the relationship with their partners. And as I mentioned before, they can also have the urogenital symptoms of menopause, including dryness, dyspareunia, and vaginal irritation. So what are some of the options for treatment? We usually start with recommending lubricants for sexual symptoms. And these come in many different types, the most common being water and silicone-based. The water-based lubricants have glycerine propylene glycol within them. They are safe to use with condoms. They're not usually irritating. However, they can dry out with extended activity. And another option is silicone-based lubricants, and these contain silicone polymers They are also safe to use with lubricants, and they are the advantage of the silicone-based lubricants are that they are longer lasting and waterproof. Some women, though, prefer some of the products that they already have available at home, or that they can buy more easily. And these include things like petroleum jelly or Vaseline, baby oil, as well as some common oils that are present in a home, such as olive oil, coconut oil. These do tend to cause more irritation to the vulvar skin, so I tend to not recommend that women buy products that are specifically made to be used in the vaginal tissues, such as the lubricants, water-based or silicone-based lubricants. Now, what about moisturizers? Those are actually different from vaginal lubricants. They are also available over the counter without a prescription. They are recommended to be used independent of sexual activity, meaning that they really need to be used regularly, up to 2 to 3 times a week for them to be effective. The way they work is that they will rehydrate vaginal tissue by adhering to the lining of the vagina, and thus will lead to alleviation of vaginal dryness and atrophic vaginitis. So for vaginal moisturizers to work for women, they really need to be used on a regular basis, and not stop once their symptoms resolve. So to summarize about the vaginal lubricants and moisturizers, the lubricants are meant to be used prior to sexual activity, and they help reduce friction. Moisturizers are to be used regularly, several times a week, and they help retain moisture and relieve symptoms associated with vaginal dryness and pain with intercourse. So what about vaginal estrogens? Are they safe? What is available for women to use? The first ones that came out were vaginal estrogen creams, and this is an estradiol cream as well as a conjugated estrogen cream. It comes in a tube, and you attach the applicator to the tube, and then squeeze some of the cream into the tube, and then place the tube in the vagina and squirt the cream in. There's also a vaginal ring that is placed into the vagina and left in for 3 months, and it releases a small amount of estrogen on a daily basis. There's also a vaginal tablet, and there's 2 kinds of those available. They come with an applicator. The tablet is at the end of the applicator, and you put the applicator in the vagina and insert the tablet in. Lastly, there's a vaginal insert. It comes in 2 different strengths, 10 micrograms and 4 micrograms. So that's actually the lowest amount of vaginal estrogen that's available for women to use. And all of these need to be used up to 2 times weekly. So what about specific advantages and disadvantages to some of these products? The cream, it has been around for a very long time. It can be potentially messy. Some women find that the cream comes out of the vaginal tissues afterwards, and it tends to stain or go on the underwear. It's used 2 to 3 times weekly, as a lot of these products are. There is more of a potential for some systemic absorption with the cream. However, advantage of the cream is that it can be placed on the vulvar tissues as well, which some of the other products cannot. The tablet is used twice weekly. There is minimal systemic absorption. It's a fixed dose, and it's easy to use, as is the insert. The advantage of the insert is there's no applicator, which some people prefer, as well as the fact that it's a lowest dose available at 4 micrograms of ethinyl estradiol. The ring is convenient for a lot of people because once it's inserted, you don't need to do it. They don't need to do anything for the next 3 months. It releases a small amount of estrogen on a regular basis. However, for some women, it doesn't work, especially if they've had a hysterectomy or if they have prolapse, the ring doesn't stay in, and sometimes it can be felt by sexual partners as well. It is fixed dose, and there's minimal systemic absorption with the ring as well. So how does vaginal estrogen work? It actually lowers the pH of the vagina. It thickens the epithelium or the skin of the vaginal tissues, It increases the superficial cells as well as the capillaries underneath the vaginal epithelium. And as a result of this, it alters and improves the bacteria of the vagina, which may lead to less urinary tract infections as well. So what about safety? Unfortunately, there is an FDA warning that is present on all estrogen products, and this includes the vaginal as well as the systemic estrogen. It's the same warning for vaginal products, even though there is very little absorption with the vaginal products. This FDA warning states that the use of estrogen can cause an increase in cardiovascular disorders, endometrial cancer, breast cancer, and probable dementia. However, there's actually no data for an increased risk of any chronic diseases with vaginal estrogen compared to systemic estrogen. And this is present in the Nurses' Health Study, as well as there was a very large Cochrane database review. This looked at 30 randomized controlled trials with more than 6,000 women. And what they found is that there's actually no difference in overall body of evidence in efficacy or adverse events between the various vaginal estrogen products with each other or with placebo. So unfortunately, even though the FDA labeling has not changed, even though people have the North American Menopause Society has tried to get the labeling to change, the FDA has not changed the labeling for vaginal estrogen, and we have the same labeling for vaginal and systemic hormone therapy at this time. So what about absorption? What about the serum levels? As you can see, the serum level of estrogen for women at baseline in menopause or with placebo is around 4 to 5 picograms per mil. If you use the vaginal tablet and the inserts, you have pretty much the same serum level that you had at baseline. So it really does not increase serum levels. With the ring, average levels tend to be around 8 picograms, which is a slight increase, but certainly not a very significant increase. The cream can have varying levels of absorption depending on how much cream the patients are using. So the levels can be variable, but overall, it's still much, much lower than with the systemic hormone level treatment used with blood levels for hormone therapy regimens. What about patients who are on aromatase inhibitors? So certainly women who have a history of breast cancer, who are on aromatase inhibitors, they are on medicines to reduce their estrogen level, even smaller than baseline. So baseline estrogen level, as I mentioned, for postmenopausal women is 4 to 5. And in this group of women, baseline levels are in the range of 1 to 2 on average. These women can have vaginal symptoms and sometimes do need treatment with vaginal estrogen, especially if lubricants and moisturizers are not enough to help with their symptoms. So if you look at the levels at 2 weeks, there does appear to be a slight increase in level. And this is really due to the fact that as initial use of estrogen, as the vaginal epithelium is getting thicker, there is more absorption of the estrogen product when women first start estrogen therapy. However, at 4 weeks, it comes down and the median level of estrogen comes back to the baseline level that women would have if they were not on aromatase inhibitors. So most people would say that you would want to start with vaginal lubricants and moisturizers for women who are on aromatase inhibitors. However, with a select group of women with discussion with their oncologist, they may benefit from a topical estrogen therapy for their symptoms. And if I was going to prescribe that, I would recommend the lowest amount of estrogen, which is the estrogen at 4 micrograms to start with, because that would have the least amount of absorption, potential absorption into the bloodstream. So what about non-estrogen products? Is there anything out there that women can use that is not estrogen? There's actually two other products available. One of them is prasterone, which is DHEA. It comes as a vaginal insert. It's synthetically equivalent to DHEA. It is FDA approved for the treatment of moderate to severe dyspareunia. It is an insert that needs to be used daily. As I mentioned, all of the estrogen products could be used twice a week for most patients. So this is something that one needs to do daily for it to be effective. DHEA is converted to estrogen and androgens in the body, and it has been shown to help improve vaginal epithelial cells. It lowers the pH, increases in parabasal cells, and an increase in collagen. So the initial data for DHEA, I'm just showing you two different studies. And what it showed was that women had moderate to severe symptoms prior to use of the product, and the women who used placebo at 12 weeks had some improvement. However, the improvement was greater for women who used who were on the progesterone group. So in general, it does help, and it is an option for some women who are not able to tolerate vaginal estrogen or who don't have relief from the vaginal estrogen products. There is one oral tablet that's also available and is FDA approved for the treatment of dyspareunia and vaginal dryness. And this is ospemifene. It's a selective estrogen receptor modulator. So these are synthetic estrogen products that work at some parts of the body and not at others. So ospemifene does help with it works as an estrogen at the level of the vagina, but not at other parts of the body. It is a pill that one needs to take daily, and it has been shown to help decrease the vaginal pH, reduce parabasal cells, and increase superficial cells. So the initial data for that, as you can see, vaginal dryness symptoms with placebo changed a little after using the two strengths of tablets with the ospemifene. However, certainly patients had greater improvement with the use of ospemifene than they did with placebo, and that's true for dyspareunia as well. So that's another option that some patients may want to use as their treatment modality for their symptoms of genitourinary syndrome of menopause. What about laser? There is some, I think some of you might have heard of advertisements for people recommending laser therapy for genital symptoms. And what is the data for it? So first of all, it's not FDA approved for this indication. What is done, though, is that there's a probe that is placed into the vagina. It releases a small amount of energy, CO2 laser, and it creates small cuts in the vaginal tissues. And as these cuts heal, there's increase in collagen, and it helps with some of the symptoms of vaginal dryness and atrophy. And there is some histologic studies that do show that the skin of the vaginal tissues does improve. So you do have that improvement. However, there's really no data that this is helpful compared to symptoms, compared to sham treatment with laser. So these devices are not FDA approved for any symptoms related to menopause, sexual functioning, or incontinence. And unfortunately, there have been some reports of risks of vaginal burns, scarring, chronic pain, and pain with sex associated with laser use. This is a busy slide, but it was published last year in JAMA. And this is one of the first studies that looked at CO2 laser treatment versus a sham laser treatment. So basically they had 85 women. The study was done in Australia, and they divided the women, randomized them into laser treatment and sham treatment. And what they were looking for was to see if women had improvement with the CO2 laser. And as you can see, there actually was no difference between the two groups. So the women who had laser treatment had an equal response to the sham treatment. And this is one of the reasons why laser at this point is not FDA approved for the treatment of GSM. So to summarize, in terms of treatment options for sexual problems, things that help are regular vaginal activity, including intercourse or devices, which increase blood flow to the vaginal tissues, lubricants and vaginal moisturizers. And in some women, they may need lidocaine. At this point, we cannot recommend laser as an option for treatment, as well as hormonal options, which are low-dose vaginal estrogen therapy, DHEA, and oral osmorphine. Systemic hormone therapy is reserved for women who have other systemic symptoms. So in conclusion, GSM is a common problem. It does adversely impact the health and quality of many midlife women. It is often unrecognized and undertreated, and there are effective and safe treatments available, including lubricants and moisturizers, low-dose vaginal estrogen therapy, vaginal DHEA, osmorphine, and pelvic PT for women who may have issues with muscle tension in the pelvic floor. And low-dose vaginal therapy generally does not increase systemic hormone levels and have high degrees of safety. Thank you.